in most settings of care, patients who have what we call BCLC stage B, that would be a patient who might have a significant burden of disease, multi-lobar disease, but with no evidence of extrahepatic spread or macrovascular invasion. In other words, a tumor that has not invaded outside of the liver and has not gone into the portal vein, the hepatic vein, or the hepatic artery. Most people would refer these patients to a competent interventional radiologist in order to ensure that the patient is able to benefit from treatment in that setting. And in patients who have fairly limited disease burden, this intervention, which could be ablative therapy or more commonly these days, is in the form of transarterial chemoembolization or transarterial radioembolization, actually offers patients a significant benefit in terms of improvement in survival. In patients who have macrovascular invasion or extrahepatic spread, or in many patients in whom the burden of disease is so extensive throughout the liver, then one would not realistically conceive that the patient would survive locoregional therapy that affects most of their liver, because their liver function would decline very significantly. In those patients, reasonable minds would agree that systemic therapy is the way to go from the start in those patients. And so for BCLC-C patients and a subset of BCLC-B patients, sometimes we like to refer to those patients as the bad Bs, the Bs that have extended throughout the liver and do not allow a radiologist to safely administer therapy. Systemic therapy is the way to go. And when systemic therapy is contemplated, our current algorithm calls for 2 tyrosine kinase inhibitors that are currently FDA approved as first line for the treatment of HCC. These include sorafenib, the first FDA approved drug for that purpose almost 11, 12 years ago, and lenvatinib, a drug that was approved in the past 2 years as a first-line treatment for patients with HCC. Both these drugs are tyrosine kinase inhibitors, and they have somewhat different targets, although a key target for both to varying extent are vascular pathways, specifically VEGF targeted pathways, in the case of lenvatinib, PDGF, RET, and KIT. All of these are pathways that have been very, very significantly involved in the pathogenesis of HCC. The evidence that supports the use of lenvatinib in the treatment of HCC comes from the REFLECT trial. REFLECT, as I will remind this audience, is an international open-label randomized phase 3 non-inferiority trial, the results of which were published in The Lancet, with Professor Kudo as the first author almost 2 years ago now. The study basically looked at sorafenib as a comparator arm versus lenvatinib in the first-line treatment of HCC. And the findings, which are well known to this audience, include a median survival time for lenvatinib of 13.6 months versus 12.3 months. This met the non-inferiority criteria. Additionally, for lenvatinib, a few interesting other highlights of the study included a progression-free survival, which in the case of lenvatinib was 7.4 months versus 3.7 months for sorafenib, for a hazard ratio of about 0.66. These findings led to the FDA approving lenvatinib as a first-line agent in addition to sorafenib.